Welcome, and thank you for joining us today for the Sarcopenia and Cancer Survival, Finding Gaps in Future Research. My name is Vanessa Torres, and I will be your WebEx technical support host. Before we dive in into today's meeting, I wanted to provide some quick information on the WebEx platform. All lines have been muted on entry and will remain muted for the duration of the webinar. Please submit questions throughout the presentation using the chat or Q&A panel and select all panelists. A moderator will ask the comments and/or questions on your behalf at the end of the presentation. If you require technical assistance, please feel free to contact me, the host, via the chat panel, and I'd be happy to assist you. If you need closed captioning, please refer to the link in the chat panel. We also wanted to make sure you are aware that today's webinar is being recorded. And now I'd like to turn it over to Dr. Joanne Elena to introduce our speaker.
Thank you so much, Vanessa. And welcome everyone to the first Body Composition and Cancer Outcomes Research webinar series sponsored by NCI. Many of you have attended some or maybe all of the great talks that have been over the last couple of years that were sponsored by Kaiser Permanente Northern California's own Bette Caan. So it is very fitting that we have Dr. Caan as our first speaker in our series today to give us an overview of sarcopenia and cancer outcomes. She's a senior research scientist and nutritional epidemiologist in the Division of Research at KPNC, where she directs a research program in the examination of modifiable lifestyle risk factors for the prevention and progression of cancer. She's really focused on body composition and energy balance risk factors. She's part of a very productive team and has authored or co-authored over 450 publications. Knowing her, I'm sure that number is even higher now, and has held several large grants at NCI, which is how I was fortunate enough to get to know her. Betty's the first person to get me excited about body composition, which started probably, 7 or 8 years ago with the first submission of B scans and C scans, two of her large R01 studies. And fortunately, she hasn't stopped bringing people into the world of body composition research. I expect her talk today is going to generate many interesting questions. Please enter those in the chat box at any time during her talk. And once she's finished, I'll ask her the questions and we can lead a discussion, and Dr. Caan will answer those questions for you. So please join me in welcoming Dr. Bette Caan, quietly, I guess, since you're all on mute, but we can imagine the thunderous applause. So thank you very much for kicking off this series, Betty.
Everything on my screen, is it in the mode that you can see it in?
Not just yet, Betty. I think you have to, I gave you the presentation mode, so you should be able to share your screen now at the bottom of the toolbar. Okay, let's see. It's the presentation mode. The bottom of the tool mode is, let's see, I'm sorry, and show, no, let's see. All right, you just have to, so let me go back to this. Hold on a second. So if I go to the WebEx and it says, is it share? No, let's see. Yes. So on the WebEx panel, it should show you a box with an up arrow share. Yes, and you should be good to go.
There you go.
All righty.
All right, and now I have it in presentation mode. Let's see, let me get it in present. Right, now do you see the right thing?
Yes, looks great.
Beautiful. Okay, so one, thank you to Joanne Elena for that lovely introduction, and really thank you to NCI and Joanne Elena for taking over all the administration part of this seminar series. It's so nice to be on this end and not the other end. And a third thank you to inviting me to be the first speaker. Joanne asked me to kind of speak about where we are at in this field, and that's always a large task. And so today I'm going to attempt to discuss with you the importance of sarcopenia and low muscle radiodensity in clinical outcomes of cancer patients. I'm going to then go on to talk about some of the research gaps in muscle and cancer research, And then talk about future directions to better understand sarcopenia, muscle, and cachexia in cancer patients and where we should be going with this work. So first I'm going to start with that this field has really exploded and gained a lot of interest in 2010. And I want to give credit to my colleague Carla Prado and her mentor Vicki Baracos for really in 2008 publishing this seminal paper that used opportunistic CT scans to actually denote body composition and come up with body composition of cancer patients. And you can see that shortly after this paper was published, that what happened is the number of papers in this area really exploded. And last year, we were up to over 350 papers in sarcopenia and cancer research. And to this year, we're at 287 as of September, so we'll surpass that. And the method that they really came up with is to use single slices of opportunistic CT scans that are done both for clinical use and surveillance use, and to take a single slice at the L3, and based on the density of these tissues, you can see here that you're able to segment out the different tissues. And so in the red we see is the muscle, the blue is the subcutaneous adipose tissue, the yellow is the visceral adipose tissue, and the green is the obvious fat that is in the muscle that we can actually see. And this is correlated. People have looked at this very nicely to see how well it correlates with whole body. And the correlations for both muscle and fat are in the 0.9 range. So we've been using this as kind of a surrogate for muscle mass and adipose tissue mass. So today I'm going to talk about the clinical implications of sarcopenia, but I'm going to focus on three outcomes that are really important to people who are in the cancer world. That is mortality, surgical complications, and chemotoxicity. So first, to talk a little bit about the prevalence of sarcopenia. It's when I first got into this field, it surprised me, and this is using CT data, how high a prevalence it was, even among people for breast and colorectal cancer who we know have good survival, and we're seeing that in the 30 to 40% range. And then if you go to the more refractory cancers like pancreatic and liver, they're as high as 50 to 60%. So it is not a rare occurrence, and it is quite prevalent in people who present with cancer at diagnosis. The first study was, the first meta-analysis study, and I quote this one all the time, was done by my colleagues Shlomit Shachar and Grant Williams at the University of North Carolina, where they looked across a whole bunch of studies of solid tumors, almost 8,000 patients, 38 studies, and they were able to demonstrate that sarcopenia led to a 44% increase in overall mortality. More recently, in Cancer Medicine, this was published in September of this year, you can see here how they looked across a whole group of different cancers and a whole group of different prognosis outcomes, overall survival, disease-free survival, recurrence, and you can see in every single one of these, and this is an umbrella review of meta-analysis, so much work has been done in this area that they're now taking meta-analysis of meta-analysis, and this work here shows that, the hazard ratios go from anywhere from 1.11, an 11% increased risk in ovarian cancer, to over 2 hazard ratios of over 2 in cancers like gastric cancer and liver cancer. And people say, well, what about cancers like breast cancer? Survival is very good. They have high cure rates. Do we still see those same kind of relationships? And this was a meta-analysis published again this year in 2020 that demonstrated if you look at studies that have been done in breast cancer, you have like a 71% increased risk of mortality in those people who have sarcopenia. And then they looked further by disease stage, because one would think that it'd be more severe in metastatic versus non-metastatic, and again, the cure rates are good in non-metastatic people, But you can see that surprisingly the risk was even higher in non-metastatic disease, hazard ratios of 1.91. And in fact, in metastatic disease, the two studies that they used were not significant. So it is a disease. I mean, even in curable cancers like breast cancer, sarcopenia is still an important risk factor. What about surgery? Well, the surgeons were kind of really the first group of physicians to be on the bandwagon with this. It was much more incorporated into surgery than it is into oncology at this point. And that's because they were really interested in the short-term outcomes, and they understood that people who were frail, and sarcopenia is a big part of frailty, did not do as well as patients who were not frail. And these are the things that they were looking at because those are important outcomes for them. And the reason is because these things have a significant impact on the healthcare system. When you have, 30-day mortality and readmissions rates, those are important outcomes that are of interest to surgeons. So if you look at the data on surgical outcomes, again, and I'm only presenting to you, there's been so much work in this area that I was only really looking for meta-analysis and not individual studies, but here's a study on people undergoing gastrectomy surgery, and you can see that sarcopenia patients have over 3 times the risk of poor post-operative outcomes compared to people who don't have sarcopenia. And then if you look again, the same study that was published in Cancer Medicine, they went, again, an umbrella study of all the different meta-analysis. And you can see, again, they looked at different cancers, different types of complications. Every single meta-analysis was significant, ranging from a hazard ratio of 1.35 to over 5 and 6 for these 2 studies in gastric cancer. What about chemotherapy, effect of muscle mass and chemotherapy? And this is a study that's quoted so often by, again, my colleague Carla Prado, where she looked across different chemotherapy regimens to see whether or not people who had low lean mass versus normal lean mass had higher percentages of dose-limiting toxicity, and found that patients with lower lean mass are much more likely to experience dose-limiting toxicity. This was a slide I got from Vicki Baracos, where she demonstrated here, I thought, and very interesting, a small study, but demonstrated that if you dose oxaliplatin on kilograms per lean body mass, that you can come up with a very nice cut point below which people do not have dose-limiting toxicity, but above which there's quite a bit of dose-limiting toxicity. And I mean, this is an area of a lot of interest that people are now thinking about. Rather than dosing on BSA, should we be using lean mass, or should we at least be supplementing lean mass into our BSA calculations to get at better estimates of who might get toxicity? This is from our own group, Elizabeth Feliciano's paper in breast cancer patients, where she found people on anthracyclines and taxane-based chemotherapies. She demonstrated that it was not, in fact, skeletal muscle, but it was intramuscular adiposity that actually increased the risk of low relative dose intensity, which is a combination of both dose reductions and dose delays. And then, again, Elizabeth's work in colorectal cancer, when you compare the low versus highest tertile of muscle, we were able to show that those people who had low muscle had higher rates of early discontinuation, more treatment delays. And when we looked at dose reduction, she found that the results were much stronger for 5-FU than they were for oxaliplatin. What about low skeletal muscle radiodensity? So I explained to you how we look at the different aspects of body composition, but this is interesting here with muscle. If you see here in the red, this is all colored as muscle. But if you can look more closely, you can see that there's different densities within that muscle tissue. And so the red is the highest quality, or the most dense tissue. But the muscle that's in the area of the yellow and the blue range means that there's fatty infiltration into the muscle, and so it's less dense. It's looking more like fat. and that the lighter blue is actually the fat that we can see. It's in the Hounsfield unit range of the fat. So when we take together the average density of this, we can determine whether or not people have low skeletal muscle radiodensity, which is an indicator of fat in the muscle, intramuscular fat, versus whether or not they have very dense muscle, which is more all in the red range. And so what does the data tell us about low skeletal radiodensity? And again, there's so many studies in this area that I picked the meta-analysis, but you can see here, this is one in colorectal cancer, and you can see that those people, myostatosis is another term that we use for fat in the muscle, but you can see here that those people who have low skeletal radiodensity have an increased risk of both overall and cancer-specific survival in colorectal cancer, and it's about a 50 to 60% increased risk for both of those outcomes. Here's a study again that was done by the group at North Carolina. The first author is Alexia, but Grant Williams is a senior author, and they now looked at myostatosis across many different cancers. They looked across GI and lung cancer, breast cancer, gynecological cancer, renal cell, pancreatic, liver cancer, gastroesophageal cancer, and colorectal lymphoma, and came up with overall a hazard ratio of 1.75 increased risk for those people who have myostatosis compared to those people who don't. And the only cancer in which they did not see a significant increased risk was breast cancer, but across all of the rest of them, very few studies have been done, and I can say we were one of the groups that contributed to not having an increased risk. So more work needs to be done in that area as well. So to conclude that part of it, so, I've demonstrated here that low muscle mass sarcopenia is related to poorer cancer prognosis. It is related to poorer surgical outcomes and increases the risk of chemotoxicity. And that low radiodensity or myostatosis is related to poorer cancer prognosis as well. So I think while the evidence is convincing and there's consensus in this area, it doesn't mean that we need to stop this research in this area, because I think there's still room for improvement. And where do I think some of the research gaps are? And I want to say again that these are just a couple of the research gaps that my research group is of interest, and so I picked these. But for instance, I'm not going to talk anything about mechanistic work, and I think there's a lot of work to be done in that area. But I'm going to talk about these three things: better methods, both in muscle measurement and statistical analysis, and then reference population, disentangling aging from cancer, and then prevention and treatment about interventions to build muscle. So let me first talk about D3 creatinine. Traditionally, we have depended on DEXA as a surrogate measure of muscle mass, and it measures total lean mass, and you can look at appendicular lean mass, the limbs, and that's what traditionally people before CT have depended on. Now we have CT, but several years ago, Bill Evans and his group came up with this measured D3 creatinine, and giving labeled creatinine, they can, using a single spot fasted urine that's collected 3 to 6 days after the dosing, they can measure muscle and functional measure of muscle. And they use the labeled and unlabeled creatinine, and then the creatine are measured, and those are put in an algorithm to determine the total body creatine pool size and then skeletal muscle. And why is this important? Because they have done some work in this area and have done work to demonstrate that D3 is actually much better than DEXA in predicting function. And this is the next two studies I'm going to demonstrate are in older men. And we're the first group, I'll talk a little bit about that, but we're the first group that are doing it in cancer patients. But in older men, what we're seeing is here, this is work by Peggy Cawthon, the works of Bill Evans in the Mr. Oz study, and they're demonstrating that, in fact, D3 creatine is a much better measure of predicting walking speed in these older men, lower extremity power, and the short physical performance battery score, whereas the DEXA, the appendicular lean mass index, does not do a good job at all. And the only thing in where they're comparable is in grip strength, which makes sense when you're looking at appendicular lean mass because you're really measuring the mass in the limbs. They also just published another paper, which I thought was very interesting, that demonstrates when you use D3 to assess muscle mass, and they looked at mobility limitation, that low muscle mass was really the predominant risk, and obesity was not associated. So again, if you look at DEXA compared to D3 muscle, and the reference group here are people who have a lot of lean mass and low fat, and if you use DEXA, those people who have low lean and low fat have a reduced risk, which is not the case when you use actually D3, that those people with low muscle, even though they have low fat, have an increased risk. And the risk of people with high muscle, high lean mass, and high fat are much reduced, that the high muscle here is protecting them, that, you know, the risk compared to 3 versus 1.8. So I think that this is very interesting work to demonstrate that if we have better measures of muscle mass, we might be getting very different results. Now, the jury is not out. Our group has been doing this in cancer patients, and other groups have been starting, a couple of studies have been funded to do that. And I think we're going to learn more about, you know, how this might play out in cancer patients. So far, we've had good luck. This is a method that people have done either by mail. Totally, in our group, we're giving people the pill when we see them, and then they're mailing it back. But it is a method that, if it proves to be really, you know, good, is highly scalable because it can be done by the mail. What about scaling muscle mass to height? So what we've been doing traditionally is we've been using the muscle mass area at the L3 vertebrae, dividing it by the patient height, and accepting that as a surrogate marker of sarcopenia cachexia. And we're calling this the skeletal muscle index. And my colleague Justin Brown has been doing work in this area along with Steve Heinfeld to kind of think about whether or not this is really the right thing to be doing. And so, you know, we do this with body mass index because if you plot the log of height to the log of body mass, you see the slope is 2. And the goal of doing an index or putting it over height squared is to get it not correlated with height. And so body mass indexes does a really nice job of doing that. If you look at muscle area, and this is from some data from our colorectal cancer study, you can in fact see that the slope is not 2 on these lines. If you do the log of height to the log of muscle area, the slope is much lower, and in both males and females. And here on the right-hand side, you can see what is the scaling muscle that creates, what scaling should we be using that creates a measure that's not correlated with height. And you can see here that for females, it's below 1, and for males, it's slightly over 1. So actually just using the muscle area is probably a much better measure that's independent of height than actually scaling it to height squared. And so that's another way we can start to think about, you know, statistical techniques that we're using to understand better this data and perhaps have data that's, you know, less inconsistent. What about cutoffs? So this has been an area that I've been, you know, kind of interested in a long time, and recognize that, you know, it's a valuable thing for clinicians to have cutoffs to define who might be sarcopenic or not. But in the arena of research, when we're trying to really look at associations and look at relationships, these may not be the best things to have. And so, you know, back to this paper that Carla and Vicki Barricos published back in 2008, where they came up with specific cutoffs for the L3 skeletal muscle index, and those cutoffs were 52.4 for men and 38.5 for women. And that paper has been cited over 1,700 times since 2008, and it's really become the standard. I still see, papers that I reviewed today actually that are using those cutoffs. So my colleague Patrick Brosher, and this is really, as I said, it takes a village. This whole work takes a village, and I've been fortunate to work with just numerous people who are really brilliant in this area and have contributed to all of my thinking. So I have to, credit them as well. And these are some slides that Patrick sent me. But, this categorization implies unrealistic relationships that, again, and he presented it this last year or the year before in our seminars, but to demonstrate, again, that when you categorize that, you assume that everybody below a certain point has the same risk, and everybody conversely above that point has the same risk. And that more generally obscures the true dose-response relationships. And we don't really think that's very realistic. We don't think that someone with a skeletal muscle index of 50 has the same risk as someone who's 20, and that someone who has 50 versus 55 is very different. So I think we need to rethink some of those. There are some key analytical limitations in this, that these data-driven cut points are study-specific, that, when people do these cut points, and they're based on survival. I mean, the original cut points were based on survival. I didn't mention that, but it looks at what is the inflection point below which survival really starts to increase, and above which survival is much better, and that's how these cut points are come out. And so what happens is that you have, depending on your population, you can have very different cut points. And that was exemplified by, we wrote a letter to the editor in a paper that was done in Advanced Cancer, and they were looking at people, I think it was with pancreatic cancer, and one population had 20% prevalence of sarcopenia and the other had 60%. And they were not that dissimilar, but they came up with very different cut points. And so one was a much more liberal cut point where they had, many more people who they defined as sarcopenia, and the other one was a much stricter cut point. And so I think these data-driven cut points, are problematic for that reason. But more importantly, it also throws out important information. So it's can be viewed as extreme rounding, and dichotomization forces a binary covariate to explain what we know is a wide range of outcomes. And you have far more than two values that predicted to explain the outcome. And this dichotomization actually reduces our efficiency. And it's been, this paper in 2006 says it's equivalent to losing a third of the data. And so it reduces our power to detect effects, and then the confidence intervals become very wide. And so I think we really need to move away from that. One of the things that Patrick has talked about is us using ranges to define people rather than specific cut points. And even, again, Carla's getting a lot of publicity today, but in a recent paper that she wrote in Nutrition Interventions to Treat Low Muscle Mass in Cancer, she finally came out and said that this is a contentious topic and that cut points depend on the methodological assessment as well as the population or outcome of interest, and that the newer studies have proposed sex-specific percentiles and means and standard deviations for skeletal muscle mass based on healthy adult populations. So even in this group, our science is really evolving over the last 12 years in our thinking about this, and I think we'll be seeing more in this area as well. What about reference populations? This has been a pet peeve of mine, something I've tried to get funded over the years and have not been successful, but I think we need more reference populations to really better understand low muscle in cancer and aging, and to disentangle the two. And here are two papers that were written in 2018, both that give us some reference populations based on CT. And I can tell you in a place like Kaiser, we have hundreds of thousands of scans that are done for reasons other than in non-cancer patients that are available to actually do some reference populations that can be done by sex, by age, and by race, ethnicity. And so I think this work really needs to be done. And why does it need to be done? This is kind of the model that our group has been operating on for all the time that we've been doing our research. And, the assumption is we know that there is, from many other people that there's and works of research that there's an age-related decline about 1 kilogram per year. And we assume that there's a certain amount of muscle that persons need for healthy functional aging, and that probably level is higher for optimal cancer outcomes, and that all along the cancer continuum, even at pre-diagnosis and surgery and chemotherapy, that people lose muscle due to the tumor itself, or to reduced steps, or to the inflammatory response in chemotherapy, and that they may or may not go back, but they're always lower than where they started. But we don't really know that this is really true, because we can't really compare them to people their age and sex and race that do not have cancer. And so I think this would go a long way, these reference populations would really go a long way for us to really disentangle, what are the muscle loss due to cancer versus muscle loss due to aging. And when the clinician sees a patient, they can know how their patient compares to a non-cancer patient of that same age and sex. So I'm really a big proponent of us trying to do this, and I know that there are groups that are trying to publish more on this. The group at the Dana-Farber, under the auspices of Michael Rosenthal, I think we'll have a paper coming out soon in this area. What about interventions? This is something that my group is very interested in. We've been working in this area. I thought that this was really an interesting paper, targeting exercise interventions to patients with cancer in need, an individual patient data meta-analysis, and this came out in JNCI in 2018. And their conclusions, which I really liked, were that it's best to target specific subgroups, that even though we know exercise is good for everybody, during the cancer continuum, we may have different effects depending on which patients we target. And their conclusions were that physical function interventions during treatment and post-treatment should target patients specifically with low physical function. For muscle strength, however, they said that during treatment, all patients will experience benefit. After treatments, only patients with low muscle strength would benefit most from treatment. So it's guiding us towards a more targeted approach of who we're going to really intervene on and with what type of intervention. And here's some data from some of our colleagues. Again, this is work that Justin Brown did a while ago, showing that strength training preserves muscle mass and slows decline of physical function in women who have breast cancer. This was done after treatment, and shows here that those in the weightlifting group both had lower loss of appendicular lean mass and a lower decline in physical function. This is done from a meta-analysis to show that resistant exercises increases muscular strength in adult cancer, both in the lower limbs and the upper limbs, more in the lower limbs. And then these are a couple of papers in the prehab space, which I think is a very interesting space. There's continually being a lot more done. I see a lot more work in this area. And prehab is very different for some of these different papers. Some it's a very intense prehab, some it's a very mild prehab. But more and more they're demonstrating that not only does prehab improve surgical outcomes, people are doing prehab before surgery, but that has a lasting effect to prognosis outcomes. So I think there's a lot of work to be done here in the prehab area across different cancers. And then lastly, we're doing this study, the FORCE study. It's a multiple PI study between myself, Katie Schmitz, and Jeff Meyerhart, where it's based on the data that shows that low lean mass increases chemotoxicity. And so what we're doing is strength training and protein supplementation during chemotherapy to people who are stage 2 and stage 3 colon cancer patients. And the goal is to actually maintain muscle mass or increase muscle mass with the idea that we can reduce chemotoxicity because some of these drugs are metabolized in the muscle, and so they're dosed on BSA and not lean mass. So hopefully we've randomized 130 people. Our goal is to randomize 180 people, so results should be forthcoming hopefully in the next year or year and a half, results from this trial. And then lastly, nutrients in consideration of the treatment of low muscle mass. There's a lot of work being done in protein, and we have a protein supplement in our trial, but then there's work in fish oil, and then amino acids and their derivatives, and then vitamins and minerals. So future directions, where are we going with this and where should we be going? And again, these are just some of the things that I picked out that I'm interested in, but I think we need to start thinking about the clinical translation of some of this work that we've been doing. We've been doing a lot of research, but how do we get it into the clinic? And a very nice example of this is a recent study that was just funded, my colleague Elizabeth Feliciano, we're looking at including muscle mass into established risk prediction models in clinical care, and the R01 is an informatics approach to assessing patient frailty in surgical care. And what they're doing is they're going, we have existing EHR-based frailty measures, and they're looking to see whether or not if you add muscle mass into those, we can actually improve surgical outcomes. So it's a very nice example. And if that's true, then, we can see how that could expand to other outcomes as well and be used quite nicely in clinical care. Then there's been work in understanding how early in the cancer trajectory muscle abnormalities begin to change and creating biomarkers for muscle mass change once treatment begins, so we can have some early intervention. And there was a very nice study done like 6 years ago, one of the first studies that caught my eye, about demonstrating that early on before a pancreatic cancer diagnosis, you see these elevated branched-chain amino acids, and that these tissue amino acids are derived from the muscle breakdown, support the elevated amino acid requirements of these pancreatic cells. So you can see that early on that, we have a biomarker here telling us that there might be some imminent pancreatic cancer diagnosis might be occurring in the future. We're doing some work with this part of the same group, looking at CT scans of people who had them not for pancreatic cancer, but for other reasons, and looking at controls to see if we can see changes in CT scans before diagnosis in the first 5 years before diagnosis. So I think that work is just about completed, and we're awaiting results soon to see if we see any differences there. Another group in the same group in Boston demonstrated that they demonstrated that loss of muscle mass over the first 2 to 4 months after a diagnosis was indicative of poor outcome. But then they demonstrated if you look at branched-chain amino acids at baseline and monocyte chemoattractive protein at baseline, that you can in fact see that people with higher branched-chain amino acids and lower MCP1 at diagnosis had greater future muscle loss. And I told you that future muscle loss was associated with worse outcomes. So this is promising that we can actually identify people at diagnosis who might be the patients most at risk that we have to be concerned about and target interventions. What about creating biorepositories? This is something that I've been talking about and trying to float the idea, and hopefully we'll get some traction in the near future, and then talk a little bit about automated software and where we're going with that. So this whole idea of biorepositories of CTs, colleagues in other disciplines, like I said on pancreatic consortium talk, and they're storing all kinds of CTs, imaging CTs, and I think as a group of people interested in body composition research, we should start to think about creating a biorepository. And where that sits, it would be a point of discussion. But some of the things that we need to consider are, we need to have adequate storage, not only for the images and their derived measurements, but all the associated non-imaging data. We need to make sure that they're identified and encrypted. How do we transfer them? What's the best way to do that? Importantly, what would be the access to use and the legal considerations? Who's going to own these scans, and how do people get access to use? And then all the management issues about the formats, the image quality. Do we only accept certain ones that are high image quality? What are the common data elements that we can have across them? And then our ability to link to external data. And then lastly, the analytic issues that, I talked about. Do we come up with a common set of how we're going to, use these scans and analyze them and decide on metrics and standards there? So I hope to see more work in this area. I think it's really a promising area that we'll all benefit from. And then this is from my colleague Faisal Beg and Kartik Parpari, who have this company called Voronoi Health Analytics, and they were generous and shared some of their slides with me. And it's really going from 2D single slice to this fully 3D body composition analysis. And you can see here on the top that we actually, this is what we're doing now, most of us. We're taking a single slice, we're looking at the muscle area in 2D and the fat area in 2D. But they really propose to use all slices and to go to, muscle volume and fat volume, and think that, that would give us a much more accurate measure of total body fat and total body muscle. And they even want to go beyond that and look at specific organs, look at lungs and kidneys and spleen and liver and measure those kinds of things as well. And here you can see, 3D distributions of visceral fat, skeletal muscle, and bone. And you can see here, when you're looking at the whole body, you can create Z-scores that, give you differences between people. This is the visceral fat score, and these would be the muscle scores. So I think that that's really fascinating. And they are proposing also to do an automated scoring of liver steatosis, an assessment in sarcopenia. And I know people have interest in calculating liver and fat and seeing how that correlates with metastasis and other measures of interest. So I think that there's a lot of promise in this area. And I picked out one of the papers. I was contacted when this talk was advertised by someone at the NIH that I didn't even know about, who was already working in this area, and he sent me this paper. Ronald Summers is the senior author, but it's a great example of how you can use these different automated CT biomarkers for prediction. And here he's looking at cardiovascular events and mortality, and it's in an asymptomatic screening population, but you can see that he incorporates lots of both 2D and 3D measures, but, lots of different measures, and to come up with good predictive analytics of how we can predict different outcomes. And, I can see this being used in predicting cancer and predicting cancer outcomes. And these are things that, some of them where we're traditionally using the muscle density, the L3 level, and the visceral to subcutaneous fat ratio, but also including liver density and aortic calcification score and vertebral trabecular density. So I think it's limitless. I think once we get these scans and we automate them, we get the ability and train, algorithms to be able to measure all these things, I think this field is just going to explode. And at the end of the body composition seminar that we did at our shop last year, I sent out a survey to different people to ask them, do they offer body composition segmentation services? Because I wanted to get a list of all the different people that were doing it. And you can see that the list is voluminous, that there are a lot of people that are not only interested in this area, but are doing this at their own research institutions. And some do it for, a fee, some do it for collaboration, some do it for both, and some are only doing it themselves now. But I'd be happy to talk to anybody who's interested in getting into this area of research, my experiences with the different groups and what where it might be best for them to either collaborate with or learn how to do it themselves. So this just to offer you again, that we wanted to see where the field was at, and I was surprised to see so many people. And then lastly, as Joanna Elena, she's been my partner in crime at NCI in this, and I've gotten her interested in this area, and it's been great. She's, excited about the work, and last year they came out with a administrative supplement, a notice of special interest, and an administrative supplement to look at the use of existing body composition data to understand treatment-related outcomes in clinical trials and observational studies, and they had to be in May of 2020. I don't know the exact number because she tells me it's kind of a secret, but I think it was somewhere around 7 supplements that were awarded. It could have been more. Here are 2 that I know about to give you an example about what they were funding. The first was my colleague Helena Furberg, who looked at metastatic kidney cancer patients who were treated with immunotherapy to see whether or not body composition actually predicts toxicity and survival in that group. And then Supriya Mohile at the University of Rochester, who's really leading the field in geriatric assessment for and predicting toxicity there. And she got one to look at sarcopenia and treatment tolerability, and what's unique about that is she's defining several metrics for treatment tolerability, and one is patient-reported outcomes of treatment tolerability. So I look forward to seeing results from those studies. And then lastly, the cachexia funding opportunities. We have 2 big mechanisms, important mechanisms at NCI that include a cachexia kind of question. And first is the provocative questions, and how can cancer cachexia be reversed? And they're looking for proposals that leverage a mechanistic understanding of cancer cachexia and the processes to develop treatment strategies designed to reverse cachexia. And importantly, and I think Joanna Elena was big in influencing this, that they include pre-cachexia. And that is something that many of us are very interested in. I think that what we're studying is in the realm of pre-cachexia. And then just lately, the Cancer Grand Challenge came out, again, to understand and reverse cachexia and declining performance status in cancer patients. And that's a partnership between NCI and Cancer Research at UK. And it's a very big grant, $25 million. They want a big team of, researchers to find bold new ways to understand the complicated pathways that are involved in this. So with that, I'm going to end with this to tell you that muscle and cancer research is really just in its infancy. And you can see here that, this lady on the left said, we'll be able to study sarcopenia incidence over the lifetime of these babies. But like the rest of us, her supervisor says, great, I want these results left on my desk by Friday. So I think that, we have to be patient. It's really a new field, and I think that, we're going to see a lot come out in the next several years, and unfortunately, we won't know everything by Friday. But be patient, and I thank you for your attention, and I'm happy to take any questions. Again, thank you for inviting me to come, and it gave me a chance to really get together my thinking in this area and put it in one place. So thank you. And lastly, let me acknowledge all my colleagues. Again, I said it takes a village, and I've worked with so many people over the last 6 or 7 years, and we've had many, many discussions, and they've taken on work, and all of this has contributed to where I come out in my thinking in this field. So I want to acknowledge all my colleagues. And then I'll stop. Thanks.
Thank you, Betty. That was just what I was hoping that you would say. I think it really sets the stage nicely. And I have a bunch of questions for you. But first, I want to make one announcement. Many people asked about whether or not this talk will be available later. And we have a webpage at NCI devoted to this web series, and we will put the presentation there so people can watch it again later. I understand it was a holiday in Canada and many people may not be able to be here. So never fear, you can go back at a later time and watch that. And then let's see, so I'll start with the first question. Why L3 as opposed to a different scan like an L2?
I think that the original work was done on the original work was done in the L4 to L5 to demonstrate the level at which it correlated best with whole body muscle mass and fat. And so I think it came from that bulk of work that showed that that was a good point at which there were high correlations with total body volume based on MRI.
Great.
And that's something that's, that you get that in the abdomen.
It seems most of the studies have looked at cancer-related outcomes, including mortality. Since sarcopenia is an aging phenotype, have studies looked at aging-related diseases, post-cancer treatment, and whether there are different trajectories of aging by muscle health?
Is there an example of what specifically they're talking about?
This comes from Saro Armenian, and so I imagine it is trying to find markers of aging, maybe physical functioning. I don't know if, Vanessa, can you allow people to speak by unmuting themselves? Is that feasible here? I know we have, good news is we have over 200 people attending this webinar, which is wonderful, but makes logistics a little different.
All right. Well, maybe go on and we can get back to them.
We'll come back.
Let's go on and,
Okay. Also, you mentioned Ron Summers at NCI, or NIH, sorry, he's not at NCI, I believe he's at NIH, the Clinical Center, and he has offered, his lab has developed and validated artificial intelligence software to compute muscle area and density on CT scans. And he is happy to discuss this work with anybody who's interested. And his email is rms@nih.gov. Yeah.
I mean, here's an example of someone I didn't know about who just contacted me, when he found about this. So,
Lots of people saying excellent presentation and asking to get the slides. And thank you for getting us to think a bit differently about low muscle. It's important to standardize this between studies. So that's more of a comment and something you highlighted. For CTs, can you say more about the CT needed, about what's needed to derive sufficiently robust reflections of body composition, for example, chest and abdomen, or just chest or just abdomen, and does the scan need to be contrast enhanced?
Okay. Those are some of the technical things that probably I'm not the best one to answer, but I can tell you that I think the current thinking is that when you look at the muscle area, most of our work, we haven't done any work with chest, but in the abdomen, most of our work has been done, as I said, in the abdomen, but that the muscle area is not as affected by the contrast versus the non-contrast, but the density of the tissue is more affected by that. And so you need to pay more attention if you have a heterogeneous group of scans that are both contrast and non-contrast when you look at the density of that. And there have been a couple of papers people can look up in the literature. I can refer you that to papers that talk about that, but that the area of the muscle doesn't seem to be as affected by the contrast. And I haven't worked in the chest area as much, so but there are people like Florian Fintelman who's done a lot of work in the chest, and you can look up some of his work and see And I think Leon Lenacek has done work in the chest. There's a group of people who have more expertise in the chest area than I do.
Great. The next question, I think, is actually for me, asking about the provocative questions and whether the cachexia question will be repeated for next year. There's no answer yet. Generally, it is different questions in the next year's provocative questions. This is the second time there's been a cachexia question, which is kind of rare. So that would make me think there would probably not be a third in the next year. However, we always accept investigator-initiated RO1 and PO1 and RO3s, and I'm happy to talk to anybody who's interested in funding opportunities for this type of work. Okay, and is intentional weight loss, which likely results in muscle mass loss as well, thought to be different than unintentional weight loss in terms of affecting cancer outcomes?
You know, I'm going to answer that indirectly, and I can tell you that we've seen data from our research group that there isn't really a relationship between weight loss and muscle loss. And again, we're talking in non-metastatic cancer people, but in fact, you know, there's always the assumption that that they're very highly correlated, and we have not been seeing that. So people can change. That's why body composition is so important, that people can change their body composition without changing their weight. So, you know, they can increase decrease their fat and increase their muscle, and it'll be the same weight, and vice versa. They can, you know, lose fat and increase muscle and be the same. So I think that to assume, you know, we haven't disentangled in our group the intentional versus the non-intentional weight loss, but I can tell you that there isn't much association between that and the cancer patients we've been studying.
Okay. Sorry, they're coming in so quickly. Lots of thank you for this great presentation statements here. Most studies adopted low muscle levels defined in relation to short and long-term survival. What is the current discussion regarding outcome-specific definitions? LOS, complication, toxicity. Should we be using the same definition for people at different phases of the, the survivor trajectory?
Yeah, I think that's a great question, something, you know, that like I thought about early on, you know, because I told you that these original cut points, which I think people are moving away from more and more, were based on survival. And then we were using that cut points to look at surgical outcomes, and we were using those cut points to look at toxicity. But the reality is, should you then be defining these cut points based on the outcome? I think that that's the question. You know, if we're going to continue to use cut points, should they be specific? If we're interested in surgical outcomes, should they be based on, you know, the inflection point at which surgical outcomes, you know, start to decrease rather than survival? And I think that that's a really valid question. So I think this whole idea of cut points is just an area that really needs a lot of rethinking and critical thinking. And, you know, when I talk about standardization of methods, I think, again, this field is in its infancy. And it's a little bit like the wild, wild west. People are just doing different approaches. And so when it comes to interpreting things or doing meta-analysis or doing systematic reviews, you have these studies with widely different approaches. And so I really think that, you know, this is, you know, my hopes in starting this forum was to start this discussion, and that we'd come together as a group of people who are interested in this area of research and really come up with some good ways to think about standardizing our method across different research groups. So that's a long-winded answer to a big pet peeve of mine. So thank you for asking that question.
Do you consider the Alberta protocol the primary method to perform CT analysis at L3? Who performs CT analysis for your group? Is it an imaging technologist, radiologist, non-radiologist physician? And what do you think the best way to go is for image analysis?
So I can tell you when I started in this field 5 or 6 or 7 years ago, and I met Carla Prado at a conference, and she said, you know, we were talking about something totally different. She said, well, have you ever thought about sarcopenia? And I said, what? I was telling her that my people in breast cancer are doing better if they... Anyway, to make a long story short, we started with the Alberta protocol, and we started doing manual segmentation in Carla's lab. And we have since started to work with people who are doing automated segmentation. And we're working both with the Voronoi Health Analytics, Kartik and Faisal, and then Michael Rosenthal at Dana-Farber doing automatic. And I really think the wave of the future is the automation. I think that's really going to allow us to bring it into clinical care. They're working, many different research groups are working on that, doing automation. Those two are not the only ones that have it. And I think it's going to allow large batches of scans to be done, you know, very quickly. And they're working on automating the L3, automating the identification of the L3. So I think that this kind of, I haven't been keeping up as much with the Alberta protocol, but I think that this idea of us doing it manually by hand and individually is really going to be something that started out the research area, but that we've moved in a direction of really doing automated. And that's kind of what we're doing now, it's automated.
Well, you have set this up perfectly because next month's speaker is Dr. Faisal Beg, and he will be talking about automated body composition from routinely acquired CT images towards 3D measurements on December 17th. We will be emailing everyone just like you received the information to register for this this webinar today. Please forward it to people that you think may be interested. It's been a wonderful first webinar. I want to thank Dr. Caan, and there have been a few questions that have not been answered yet. I will send them to Dr. Caan, and she hopes she may be kind enough to respond to you. Okay, wonderful. She'll respond to you via email. And again, I stand ready to help any way that I can from NCI's perspective, and I hope to see you all on December 17th. For Dr. Beg's talk. Thank you so much.
Thank you, Joanne. Thank you for your support over all the years in this area of research. I really appreciate it. So, well, thank you.
It's easy to support such an interesting area. It's been great. Thank you so much.
All right. Bye-bye.
Bye.